Hello, my dear students. I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for a long time and I love it. Today I'm here with a lecture which is a part of my inguinal region series. I have taken a lecture on anatomy of inguinal canal, how to draw inguinal canal to learn the anatomy, what is the anatomy of indirect inguinal hernia, and today we're going to discuss the anatomy of direct inguinal hernia. Okay, so this lecture I feel should be attended by anatomy students of first MBBS as well as students who are doing surgery in their third MBBS and by PG students who are doing surgery here. Okay, for all of this lecture would be helpful. The links to all the other lectures in relation to inguinal region series is given in the description section. Please use that. I suggest all of you go through all 4 lectures to really understand the anatomy. Right? So, anatomy of direct inguinal hernia. Question. A 50-year-old man developed a direct inguinal hernia which exited out through superficial inguinal ring. Direct hernia coming out of superficial inguinal ring. It would be surrounded by following layers except. There are layers given. Students, you cannot answer this if you don't know the actual anatomy. There is no fibbing your way through such MCQs. Again, you should know the anatomy of direct inguinal hernia because inguinal hernia is a very common disease which is treated surgically. So you have to know the anatomy to be able to operate. Plus, inguinal hernia is a very common case asked in your surgery exams. For all these reasons, let's study the direct inguinal hernia. I'm going to cover this lecture under the following headings. I won't read them. You can come back to this to understand. Just remember, in this lecture, the initial part, study the anatomy. This region is something you need to really understand. If you know this, the rest goes very fast. Okay, so focus. Very important instruction. Please keep drawing sheets and a packet of color pencils ready with you so that you should draw when I ask you to draw. This lecture is based on a few diagrams. I'll be teaching these diagrams to you during the lecture. Just practice those diagrams. You will understand direct inguinal hernia. Okay? Right. Define inguinal hernia. If you're talking about direct inguinal hernia, so what is inguinal hernia? You should know. Correct? So, inguinal hernia is an abnormal entry of an abdominal content covered by peritoneum into the inguinal canal. It does not have to pass through and through. It just enters into inguinal canal. You call it inguinal hernia. Right. Then what is direct inguinal hernia? To understand this, let us study anatomy of inguinal and lower abdominal wall region. Wall. Okay. Let's begin. This here is the peritoneum, which is lining the abdominal wall. This is one half. Okay. So the other half is on the other side. This is the scrotal sac. This is the peritoneum. This is the extraperitoneal tissue between the peritoneum and the fascia transversalis. Somewhere here is the deep ring from where the fascia transversalis continues down as the internal spermatic fascia. Oriented now? Now let's come to some structures here. Can you see these 3? The medial most, which is actually in the midline, is called median umbilical ligament or urachus. Okay, it's a cord-like structure extending from the apex of urinary bladder to the umbilicus. Here is the obliterated umbilical artery. Here is the inferior epigastric artery. Now you can see that the peritoneum seems to have formed folds over these. Each of these folds has a name to it. This in the midline is called median umbilical fold. This lateral to it is called medial umbilical fold. This is called as the lateral umbilical fold. Okay. So, between these folds there are fossae. Each of these fossae again has a name. This is called supravesical fossa. This is called medial inguinal fossa. And therefore, lateral to inferior epigastric artery, this is the lateral inguinal fossa. Got it? Okay. So this is the first diagram that you should learn to draw. Please start on a large sheet because this gets further developed in later part of the class. Okay. Having understood this, let's enter into the abdominal cavity and look at the abdominal wall from inside. Imagine that you are sitting inside the abdominal cavity. This is the urinary bladder. This, therefore, is the medial umbilical ligament extending to the umbilicus. Lateral to these two, both, are obliterated umbilical arteries, and further lateral, these two are the inferior epigastric arteries. Each is, like I showed you, covered by fold of peritoneum. So, in the midline, the fold is called median umbilical fold. On either side of midline, medial umbilical fold, and on the lateral side, lateral umbilical fold. Between each fold, there is a fossa formed. So, on either side of midline, there is formation of supravesical fossae. Between medial and the lateral inguinal folds, there is medial inguinal fossa, and lateral most is the lateral inguinal fossa. This is what you see when you sit inside the abdomen and look at the abdominal wall from the posteriorly. Okay. So this is a basic anatomy that you should all know. Okay. Right. Students should practice this diagram once to consolidate their knowledge. You should be practicing this. I won't be teaching this. Just draw it on your own. Right. We'll continue with the diagram 1. What have we understood? We have understood that there are 5 folds inside the abdominal wall. Between folds, there are fossae, supravesical fossae, medial inguinal fossa, lateral inguinal fossa, separated by the 3 inguinal folds. Okay. So, revise. This is the peritoneum, extraperitoneal tissue, and fascia transversalis. This is the deep inguinal ring. This is medial umbilical fold, and lateral umbilical fold. I think you know this much already because we've drawn this once. Let's now add the rest of the layers to complete our knowledge of this anatomy. Here is your transversus abdominis, which does not give any covering to the region. This is your internal oblique muscle. As the hernia, the canal gets formed, it gives rise to a covering that covers the processus vaginalis. This is called as cremasteric fascia. This therefore lines the inguinal canal. The fibers of internal oblique and transversus abdominis medially help to form the conjoint tendon, okay, which is present here. Remember, this is midline. This is where you find the midline. This is reflected part of inguinal ligament, which is also present in front of conjoint tendon. Those who are not understanding this, please go and see the lecture on inguinal canal, where details of all this have been explained. Finally, the last layer of muscle outside is external oblique. As you can see, the external oblique is giving rise to another fascia, which is called external spermatic fascia. In the core, of course, you can see the testis and the tunica vaginalis. So, what are the layers which are covering testis and tunica vaginalis? From inside out, there is internal spermatic fascia, cremasteric fascia, external spermatic fascia. Here is your superficial inguinal ring, which is guarded posteriorly by reflected part of inguinal ligament and conjoint tendon. All this is now surrounded by Colles fascia, Darto's muscle, and the skin. Now, this is something all of you should draw. So, let's continue our first diagram and let's begin to draw this. Believe me, when you draw it, you will understand and remember it way more. Right. So, you've learned a lot of anatomy through these diagrams. The last bit of anatomy that you need to know is called as Hesselbach's triangle. What is this, ma'am? What is this Hesselbach's triangle? Take a look. Now, you are aware of what is this. This is the anterior superior iliac spine. This is pubic symphysis. This is the inguinal ligament. This is the median umbilical ligament or urachus. This is the obliterated umbilical artery on both sides, and inferior epigastric artery. What is new in this image is presence of rectus abdominis muscle in front of all this. Because of presence of this rectus abdominis, a triangular region is now cut out here, bound laterally by the inferior epigastric artery, medially by the lateral border of rectus femoris, and inferiorly by the inguinal ligament. This triangular region is called as the Hesselbach's triangle. What is it called? Hesselbach's triangle. Any hernia that is coming out through the Hesselbach's triangle is called as direct inguinal hernia. The triangle is further subdivided into medial and lateral parts by presence of obliterated umbilical artery here. This part is medial, this part is lateral. Got it? Right. So let's do this once more. Here the triangle is formed laterally by inferior epigastric artery, medially by lateral border of rectus femoris, and inferiorly by inguinal ligament. This is the Hesselbach's triangle divided by obliterated umbilical artery into medial and lateral parts. Got it? So let's define the direct inguinal hernia. Direct inguinal hernia is an abnormal entry of an abdominal content covered by peritoneum directly through the Hesselbach's triangle. If it comes directly through Hesselbach's triangle, it's a direct inguinal hernia. What is an indirect inguinal hernia? If the hernia passes through the deep inguinal ring to enter the inguinal canal, then you call it an indirect inguinal hernia. Right. So let's come back to our favorite diagram. The direct inguinal hernia has two parts to it or two types to it. If it lies medial to inferior epigastric artery, to the obliterated umbilical artery, then you call it medial direct inguinal hernia as seen here. If it lies lateral to the obliterated umbilical artery, you call it lateral direct inguinal hernia. Okay? So the medial passes forwards through the supravesical fossa. Lateral passes forward through the medial inguinal fossa. Got it? Okay. You remember these fossae, you have to keep correlating with the diagrams you have drawn or see it in your notebook. But don't just blindly move forwards. If the hernia is passing through Hesselbach's triangle, you call it direct inguinal hernia. But if it's passing through the medial part of the triangle or through the medial inguinal fossa, you call it medial direct inguinal hernia. If the hernia is passing forward through the supravesical fossa, then you call it medial direct inguinal hernia. If it's passing through the medial inguinal fossa, then you call it lateral direct inguinal hernia. Okay? Confusing? Use your diagrams to understand. Very simple. Right. So features of direct inguinal hernia. Let's learn a little bit more about this type of hernia. Direction of hernia, always directly forwards. Through the Hesselbach's triangle. Relation to inferior epigastric artery, look at the image and answer. Is it medial to inferior epigastric artery or lateral to it? It's always medial to inferior epigastric artery. If there is a hernia lateral to inferior epigastric artery, what will you call it? Indirect inguinal hernia. Good. Relation to deep inguinal ring, it does not pass through the deep inguinal ring. Who passes through deep inguinal ring? Indirect inguinal hernia. Got it? Let's do these questions once again to bring you back into the game. What is direction of direct inguinal hernia? It is directly forwards. Through what? Through the Hesselbach's triangle. Relation to inferior epigastric artery, direct inguinal hernia is always medially related to the inferior epigastric artery. It always lies medial to the inferior epigastric artery. What about relation to deep inguinal ring? It does not pass through deep inguinal ring. Got it? Some basic features of direct inguinal hernia. Right. So what is a gender preference? This is again rare in females, usually more common in elderly males. What is the cause of this hernia? weakness of anterior abdominal wall, usually due to the muscle reduction in muscle tissue or weakness of muscle. This is usually seen in elderly, and that is why this is a hernia associated with old age. What is the shape of this hernia? The neck of the sac is quite wide and it's generally a forward projection. It's not like indirect hernia where it has a beautiful small narrow neck. It doesn't happen that way. It has nice big wide neck. So let's now talk about what is the meaning of coverings of hernia. See, here you are seeing a intestinal loop which has found a weakness in the abdominal wall and has herniated out. So you can see this is the loop. As it herniates out, it carries a layer of peritoneum with it. See the yellow line. Okay, so it is immediately covered by peritoneum. As it passes through the muscle, it pulls a thin layer of the muscle also. This forms one covering. It passes through another muscle, pulling another covering from that muscle. Finally, it's also covered by superficial fascia and the skin. So all these structures, peritoneum, muscle 1, muscle 2, superficial fascia, skin, everybody forms coverings of the hernia. And this narrowmost portion is called as the neck of hernial sac. So this is what I mean when I say coverings of hernia. So what are the coverings of direct inguinal hernia? Remember, the coverings will be different if it's a medial direct, and the coverings will be different if it's a lateral direct inguinal hernia. So again, best understood only through diagrams. And remember, internal spermatic fascia is missing in both. Why is internal spermatic fascia missing in both? Because none of the hernias pass through deep inguinal ring. Unless you pass through deep inguinal ring, you cannot get a covering of internal spermatic fascia. Okay? So let's begin to discuss the coverings of each of the two types of direct inguinal hernia. Okay. So coverings of medial direct inguinal hernia, medial direct. So that means we are expecting our hernia to come out through this gap. Correct? So medial direct is here between the medial inguinal ligament and median inguinal ligament and medial inguinal ligament. Between these two, or between median and medial inguinal folds, medial supravesical fossa. It lies medial to the inferior epigastric artery, does not pass through the deep inguinal ring. It lies between the medial umbilical ligament and the medial umbilical ligament. Median and medial. It lies between these two, passing forward through the supravesical fossa. Got it? It passes forward in this manner, directly forwards. Okay. If it's passing through this, can you see what are the layers it will acquire? Let's take a look. It will acquire the following layers. 1. Peritoneum, this yellow layer. 2. Extraperitoneal tissue, this white layer. 3. Fascia transversalis here. Why am I not calling it internal spermatic fascia? Because internal spermatic fascia is lining the canal. This is directly fascia transversalis. Then it acquires a layer of conjoint tendon, reflected part of inguinal ligament, finally the external spermatic fascia, dartos and the skin. The layers are as follows. What then are the layers covering lateral direct inguinal hernia? Where am I expecting the hernia to occur? It should pass through the medial inguinal fossa. Okay. So here in the lateral part of Hesselbach's triangle, let's understand the layers. So my hernia is going to be here. Again, medial to inferior epigastric artery, not passing through deep inguinal ring, common features to both. Okay. Lying between the medial umbilical ligament here and the lateral umbilical ligament here. In this gap, through the medial inguinal fossa. It passes directly forwards like this, as shown. Then what are the coverings it will acquire? Take a look. It should acquire peritoneum, it should acquire all this. Let's take a look at what are the layers. The layers that cover a lateral direct inguinal hernia are as follows. 1 peritoneum as seen here, 2 extraperitoneal tissue, the white space here, 3 fascia transversalis. Will I call it internal spermatic fascia? No. Okay, because it is not passing through deep inguinal ring. So only fascia transversalis. Then cremasteric fascia pink, external spermatic fascia brown, dartos and skin. These are the 7 layers covering the lateral direct inguinal hernia. What is missing is conjoined tendon and reflected part of inguinal ligament, which are present only medially. So they don't get involved in lateral direct inguinal hernia. Peritoneum, extraperitoneal tissue, fascia transversalis. Cremasteric fascia, external spermatic fascia, dartos and skin. These are the coverings of lateral direct inguinal hernia. Right. So this I have given you a comparison for your personal study. I am not going to discuss it because I have already discussed it. You can pause the video here and compare once. Okay. Right. Let's talk a little bit about this ilioinguinal nerve. Like I have told you in my earlier lectures, ilioinguinal nerve is a part of inguinal canal, passes through it. Okay, but what is more important is this ilioinguinal nerve supplies the lowermost fibers of internal oblique and transversus abdominis. So what happens is, when it supplies these, the contraction of these two muscles causes the functioning of the shutter mechanism. See, this is inguinal canal. These are fibers over it. When they contract, they just close the inguinal canal. This is called as shutter mechanism. So if the ilioinguinal nerve is damaged during appendicectomy or any other reason, then the conjoined tendon becomes lax. Okay, this will result in direct inguinal hernia. A damage to ilioinguinal nerve during appendicectomy causes the conjoined tendon to become weak, resulting in direct inguinal hernia. The conjoined tendon now bulges with rise in intra-abdominal pressure. This is a very important applied anatomy you should know. Why? Because appendicectomy is such a common surgery, isn't it? Right. So how did we study direct inguinal hernia? We studied it as follows. We first defined inguinal hernia. Then we studied the lower abdominal wall and inguinal region by drawing diagrams. We also studied the Hesselbach's triangle and its two parts. We studied direct inguinal hernia then under the following heads. What is the anatomy of direct inguinal hernia? Types of directs, coverings of direct, and we've also in short discussed ilioinguinal nerve and its cause. It's acting as a cause for direct inguinal hernia. Let's compare direct and indirect inguinal hernia, students. Indirect inguinal hernia comes through the deep inguinal ring, whereas direct passes directly through the Hesselbach's triangle. Relation to inferior epigastric artery, indirect inguinal hernia lies lateral to inferior epigastric artery, direct lies medial to it. Direction of indirect is downwards, forwards, medially. Direction of direct is directly forwards. When is indirect hernia seen? Since it's congenital, it's seen in children and young adults. Direct inguinal hernia, since its weakness of abdominal musculature, it is usually seen in males in the elderly. Indirect inguinal hernia has all the coverings, internal spermatic fascia, cremasteric fascia and external spermatic fascia. Direct inguinal hernia pushes the spermatic cord to one side and has coverings of abdominal musculature in that region medial to it. Indirect inguinal hernia is of 3 types: bubonocele, funicular and complete vaginal. Direct inguinal hernia is medial and lateral of 2 types. There are some questions now which should strike interested students, such as what is a reducible versus irreducible hernia? What is an obstructed versus strangulated hernia? You should all explore this. If you have problems, you can put it in the comment section. I'll give you the answers, no problem. But you must learn to explore anatomy on your own, whether you are in the anatomy year, whether you're in the surgery year, or whether you're doing post-graduation in surgery. Okay? If you have problems, feel free to put it in the comment section and I'll get back to you. Right. Let's try and solve this MCQ now. A 50-year-old male developed a direct inguinal hernia which exited through the superficial inguinal ring. It would be surrounded by following layers except it's direct. It can never have internal spermatic fascia because that fascia only acts as a covering if the hernia has passed through deep inguinal ring. Okay, so that's the answer. 65-year-old male developed a direct inguinal hernia after undergoing appendicectomy surgery. Now, I don't have to read the rest. I already know the answer is ilioinguinal nerve which got damaged during appendicectomy. Right. So, this is how knowledge of anatomy helps you to solve MCQs. Drawings help you to remember this anatomy and so on. This was a very important lecture, students. I hope you understood it. Okay. And if you have any problems, I'll be putting up these diagrams separately also on the YouTube, so you can go through those and practice the diagrams. Remember, there is no way you can mug up all this. You have to draw, visualize, and help your brain to remember all this anatomy. Okay. All right. So students, I enjoyed taking this class. I hope you enjoyed it too. See you across the screen in some other video. Thank you.